It is my great pleasure to welcome you to this incredibly exciting event. We are very excited to have Jonathan Cohen with us, a speaker for a talk that, if I can say, could not be more timely. Does global health need US leadership? And our hope in having Jonathan with us is not only to shed light on the role the US plays in global health work, but to shed light on the inequalities and the asymmetrical power structures that we know are ingrained in the structures of global health, and to help us kind of collectively think about how to move forward and figuring out what role we can all play in changing and addressing this. And to be clear, I really don't mean simply acknowledging these issues, but it's actually how we take these concerns forward into some kind of action. It is my great pleasure to introduce Jonathan Cohen, who is director of the Open Society Public Health Program, where he oversees grant making and advocacy to improve social inclusion in public health policy and practice. But I just want to say a couple other things about Jonathan. He's Canadian. He's got a strong health background, and he's a damn good lawyer. I first met Jonathan when he was a researcher with the HIV and Human Rights program at Human Rights Watch in the early 2000s. And there he was conducting investigations of police misconduct against criminalized populations, restrictions on sexuality education and access to condoms, and he was dealing with violence and discrimination against marginalized people living with HIV. And he was amazing in that work, and he continues to be so. He's been with the Open Society Foundation since 2006, first as director of the Law and Health Initiative, where he oversaw legal aid and litigation in over 15 countries. He then served as deputy director of the Public Health Program from 2012 to 2016, and he's been its director since that time. So we're really happy and excited to have you here, Jonathan. With that, the floor is yours.
Thank you, Sophia, for your leadership, your mentorship over many, many years, and for always just providing platforms and opportunities to lift up neglected issues and issues of power. Does global health need American leadership? Well, the first 100 days of the administration of President Joe Biden and Vice President Kamala Harris do suggest that the United States is at least preparing to reassert a leadership role in global health and development. Alongside President Biden's ambitious and now successful promise to vaccinate 100 million Americans in 100 days, has been a series of decisions that reverse 4 years of go-it-alone isolationism in the Trump administration's response to COVID-19 and global health in general. Indeed, the first public statement by any member of Biden's administration to an international audience was that of Dr. Anthony Fauci, President Biden's top coronavirus advisor, telling a virtual meeting of the World Health Organization that this administration would renew the support to the agency that the Trump administration had withdrawn. Within a month, the United States had pledged $4 billion to the WHO-sponsored global vaccination campaign known as COVAX, making it the largest single donor to this multilateral effort. And the same day that President Biden announced this pledge at the virtual Munich Security Conference, the United States formally rejoined the Paris Climate Agreement, which is the international accord designed to avert catastrophic global warming. This so-called America is back foreign policy promised a strong seat at the table for global health. Few things would assure this more than the nomination of Samantha Power, a former ambassador to the United Nations and cabinet member under President Barack Obama, to lead the US Agency for International Development, and as part of that role to assume a seat on Biden's National Security Council. The nomination of someone of Power's stature and diplomatic experience portends a much bigger role for USAID and for global health at the US foreign policy table. And rightfully so. For if COVID-19 taught us anything, it is that foreign policy benefits from an understanding of the relationship between health, development, and human rights and security. Pandemics have shown in the last year a singular ability to suspend economic life, deepen inequality, close civic space, and intensify authoritarian trends. At the same time, Pandemics have the power to open doors for progressive policy agendas, to bolster democratic movements, and to foster global cooperation. So any vision for 21st century American foreign policy must include the strengthening of global health and of health systems, not only as safeguards against the next pandemic, but as part of a robust vision of collective human security. Not surprisingly, however, no sooner had President Biden reasserted a prominent place for the United States on the world stage than other world leaders and foreign policy pundits urged humility. At the Munich Security Conference, German President Angela Merkel noted pointedly that US promises were only as valuable as their ability to follow through. French President Emmanuel Macron, for his part, underscored that it was time for Europe to be in charge of its own security. These comments, of course, reflect a new economic reality where the European Union's gross domestic product is now almost as large as that of the United States. And it also reflects a diplomatic reality where the US has frankly declined to ratify treaties on many matters of common global concern, such as the protection of oceans or the prosecution of genocide and crimes against humanity. Citing these realities in a New York Times column in December, Peter Beinart concluded that, quote, in the post-Trump age, leadership is a misguided and even dangerous vision for America's relationship with the rest of the globe. Beinart emphasized instead the importance of partnership and solidarity over leadership, arguing that as the United States rejoins common global efforts from climate action to COVID-19, it best serves those efforts less by dictating the rules than by agreeing to them. But this begs me to ask, is leadership the same as dictating the rules? This is a question the public health field has always thought about and has had to think about a lot in the last year. Health officials have literally been dictating the rules on everything from washing your hands, to watching your distance, to wearing a face mask. COVID-19 has made leadership a life or death issue, with the competencies of public health authorities determining the success or failure of social distancing campaigns, supply chains of essential prevention commodities, vaccine development and distribution, and everything in between. We have seen how leadership stands the test of widespread panic and uncertainty, of the seemingly impossible balancing act between economic life and public health, and of the cascading crises of COVID-19, climate change, and structural racism. Perhaps more than any other field, it is public health that has witnessed the consequences of the previous US administration's isolationist and America First approach to leadership, which cost lives by failing to learn from other nations and by choosing blame over cooperation. Interestingly, much of the literature and commentary on global health leadership in the past year has emphasized the comparative advantage of women leaders in responding to the pandemic. Writing about a month after the WHO declared COVID-19 a pandemic, the European policy experts Isabelle Francois and Marta Martinelli identified a pattern of public demand for leadership styles that they associated with women. This especially comprised the tendency to lead with compassion, which they defined as the ability to lead from within, to relate to and connect with people, so as to empower them and inspire them to stretch their thinking and innovate in the face of new challenges. Such a leadership style, they went on, runs opposite to an understanding of leadership that is hierarchical, coming from the top down, from being better informed and having exceptional skills. It points to the need for a genuine connection between those who lead and those who are led. Some of the practical leadership behaviors associated with this style include acknowledging trauma and anxiety, grounding solutions in the lived experience of diverse people, and communicating clearly. Another study early in the pandemic found that when women-led countries were compared to countries similar to them along a range of characteristics, they performed better, experiencing fewer cases as well as fewer deaths. One reason may be that these countries locked down earlier, a pattern that the authors traced to stereotypic female leadership characteristics, such as risk aversion and participatory and democratic decision-making. Other commentators have traced the effectiveness of female leaders against coronavirus to the disproportionate burden of many aspects of the pandemic on women, including the likelihood of losing one's job, having to engage in unpaid care work, or experiencing violence in the home. And still others have associated the most ineffective and dangerous responses to the pandemic, the denial of the seriousness of the problem, the authoritarian control of information, the racist scapegoating of people of Asian descent, the punishing or muzzling of health professionals, with a patriarchal form of leadership that is variously described as toxic or sovereign masculinity. While it may sound counterintuitive, one lesson that I draw from these and other reflections on global health leadership in the past year, as well as from my own experience in a global health leadership position in the middle of a pandemic, is that the world actually needs more American leadership in global health, not less. And the reason for this is that the United States has a generational opportunity as a global superpower to model a new and different style of leadership that draws on our evolving knowledge of what leadership can achieve beyond the command and control of others. And this is not just a semantic argument. It draws on a deep well of leadership theory and practice, particularly from feminist thought, that emphasizes inclusion, collaboration, and facilitation as the essence of leading. In their recently published anthology on climate feminism, All We Can Save, Ayanna Elizabeth Johnson and Catherine K. Wilkinson describe a philosophy of leadership that for them dismantles the same patriarchal power structure that wreaks destruction on the natural world. Elements of this leadership philosophy include an emphasis on making change rather than on being in charge, a commitment to healing rather than deepening structural injustices, an appreciation for the psychological and spiritual dimensions of social change that precedes the intellectual dimension, and a recognition of the importance of building and strengthening communities of interdependent people. To develop this argument, I'd like to give 3 interrelated examples of what I think a redefined style of leadership might mean for American leadership in global health. My goal in doing this is not simply to graft Johnson and Wilkinson's leadership philosophy onto our field of global health, nor am I in a position to share with you any empirical research into the public health impacts of different leadership styles. What I can do, however, is highlight what I see as some of the most problematic trends in global health over the past year, and the way in which a different and more transformational leadership style can help to chart a new course, especially if that leadership comes from the United States. My first example of how a new style of American leadership can improve global health begins with the recognition that in international health and development, power is actually an abundant, not a scarce resource. This requires confronting what economists often refer to as the myth or fallacy of scarcity. Whether it's global access to vaccines, world hunger, unequal economic opportunity, or disappearing agricultural land, progress in global health and development is very often hindered by the notion that there's simply not enough to go around. Too often, of course, we see this myth deployed against immigrants and racial minorities, whose economic mobility is cast as a threat to a native or white majority. This can also influence global health and development approaches. as when classically the solution to perceived food shortages is to reduce that scarcity by producing more food and shipping it more efficiently, which can sometimes lead to increased prices that actually make food less affordable. As the economist Amartya Sen and others have famously argued, a better alternative would be to recognize that there is abundant food to go around, but that the challenge of global development is to lift entrenched barriers to food's accessibility and affordability. This means rejecting the scarcity myth and instead tackling poverty, gender and racial inequality, corruption, and conflict. This idea that resources become more abundant if only we take a more systemic approach does not only apply to tangible commodities like food and medicine, it also applies to that most elusive and sought after of resources, and that's power. Philosophers and political scientists have long debated whether power should be understood as zero-sum or variable sum. In a zero-sum view, there's only a certain amount of power to go around. The more power I have, the less power you have. In a variable sum view, mutual gains are possible through cooperation, as long as they are offset by mutual losses elsewhere. Such cooperation can even occur in a context of vastly unequal power relations, particularly if we abandon the idea that one party is only powerful because another party is less powerful. So how is it that American leadership in global health can move beyond scarcity and zero-sum thinking? The obvious place to start would be COVID-19 vaccine diplomacy. In a recent response to accusations that the United States was hoarding vaccine supplies from poorer nations, President Biden insisted that Americans must come first. He said, quote, "If we have a surplus, we're going to share it with the rest of the world." This is classic scarcity thinking, grounded, of course, in the obvious reality that when the statement was made, there were obviously not enough vaccine doses for everyone in the world. Yet to his credit, President Biden himself went on to reject this scarcity model by announcing in the same speech that the United States would partner with Japan, India, and Australia to expand global vaccine manufacturing capacity. This capacity development is a sustainable solution that recognizes that if the know-how to manufacture vaccines is expanded, scarcity will no longer be a problem. It is smart development policy because it makes other countries less reliant on American handouts to meet their vaccine needs, instead strengthening their own capacities to respond to this and future pandemics. I think President Biden should consider taking this logic a step further and partner with public and private stakeholders to ensure that not only the manufacturing capacity, but also the technology to produce vaccines is shared globally. This move from a conflict over scarce resources to global cooperation to produce abundance is probably most important in climate action than in any other field, which is of course a major health issue. The biologist Janine Benyus draws inspiration for this move from the way in which trees in a forest cooperate to facilitate each other's thriving, rather than competing for scarce space, light, air, and water. This recognition that trees shade, shield, nourish, and defend each other marks a paradigm shift in forestry, away from plowing and thinning out forests, and towards understanding and enabling networks of underground interdependence between trees. Of course, this has a direct connection to global health, because by playing an integral role in the carbon cycle, forests help to stabilize the climate and drive sustainable development. But it also has that indirect connection, which is that by modeling reciprocity and cooperation, forests show us a new path to a new model of global health leadership. My second example of redefined American global health leadership stems from the recognition that in the past year, public health has been plagued by false choices. Nowhere has this been clearer than in the supposed choice in our response to COVID-19 between individual and economic freedom on the one hand, and collective security and public health on the other. Now, for those of us with long histories in global public health, this is an all too familiar dynamic. Public health has always been invoked as a justification for limiting civil liberties in an emergency, whether it is for involuntary or opt-out testing for HIV, forced detention of people with tuberculosis, or the creation of cordons sanitaires to prevent anyone from leaving an area infected with a virulent disease such as Ebola. Public health ethicists, human rights lawyers, and affected communities have a well-developed practice of asking whether these public health measures actually serve a legitimate public health purpose, whether their benefits outweigh their harms, and whether there are less rights-limiting ways of achieving the same public health goal. While this is obviously an important legal and human rights debate, very often it simply turns into an issue of political commitment and priorities and resource allocation, and not just an issue of civil liberties. And that is because the most effective and least rights-limiting interventions, such as directly observed therapy for tuberculosis as an alternative to detention, or comprehensive reproductive and HIV care as an alternative to forced testing of pregnant women, is typically one that costs money, or at least in the short term. And the failure to budget for these interventions only underscores the relative lack of political power of those who are most affected by heavy-handed public health measures, especially women and racial minorities. While there are clearly no shortcuts to delivering the comprehensive programs that would avert the need to restrict liberty in the name of public health, the question does remain: how do we exercise global health leadership in the face of such a dilemma? Here, it was painfully clear that the administration that preceded President Biden's played up the false choice between economic freedom and public health, probably in order to score political points and dodge the hard work of implementing comprehensive public health measures. And we could see this in President Trump's calls to free Michigan from COVID-19 lockdown, or his politically motivated attacks on Dr. Fauci as an idiot and a disaster. This tactic by the former president was as predictable as it was infuriating. What was unfortunate, in my opinion, is that many in the media and on the political left took the bait. For rather than acknowledge that the United States lacked the economic and social supports needed to carry people through the pandemic, which was a consequence of political choices made by Democratic and Republican administrations alike, critics of the former president instead doubled down on denouncing his attacks on science and public health. This was an easy target, and it was the perfect trap. For the former president must have known that the people in the greatest economic distress, the ones who had been failed most by one administration after another, would see this resort to science as further proof of the elitism and remoteness of Washington bureaucrats. In my view, a more authentic response, indeed a more leader-like response, would have been to level with people and tell them, science will not save you. Demand help from your government. In his first 100 days, President Biden has to some degree resisted this seduction of binary thinking. The American Rescue Plan could be seen as the apotheosis of the kind of help is on the way leadership that helps us break down false choices and depoliticize the pandemic. The president also regularly emphasizes that vaccines and social distancing are the way to reopen the economy, not barriers to doing so. On the other hand, at times, President Biden continues the politicization of science that he inherited. Most recently, the president told staff at the Centers of Disease Control, quote, "The public is thankful to you because it's about science." This not very subtle jab at his predecessor was, of course, perfectly understandable, given the reprehensible censorship and marginalization of scientific evidence displayed by President Trump. However, in my opinion, it did not succeed in transcending the false binary between public health science and economic freedom that President Biden inherited. And perhaps even more seriously, playing up the debate between science and liberty undercut Biden's own message of racial equity. For with the greatest respect to the Centers for Disease Control, Black, Indigenous, and people of color in the United States, in other words, those most affected by COVID-19, know all too well that the fields of public health and medicine have rarely been their saviors. This understanding should, in my view, shape the Biden administration's leadership approach to global health. In addition to providing technical assistance on the scientific dimension of pandemic control, the US government should also help less wealthy countries navigate the apparent trade-off between economic development and pandemic control. This trade-off will be even more pronounced and more subject to political manipulation in countries with high levels of poverty and weak governance, where politicians can more easily invoke economic development against pandemic control, or even weaponize public health countermeasures against civil society and political opposition. I think the United States should try to avoid getting drawn into these debates. Rather, it should work with its allies to create the economic conditions where such false choices lose their potency because people have access to the material and social supports they need to survive the pandemic and earn a livelihood. This brings me to my third and final example of what redefined American leadership in global health could look like. And that is that we need to redefine whose voices matter and who has a seat at the table. One of the most pervasive refrains of the past year has been that the pandemic does not discriminate. As President Biden said about COVID-19 immediately following his election, quote, "I know it sounds trite to say, but we're all in this together." I would hardly be the first to point out that while many wealthy and privileged people have indeed suffered the virus and its effects, this claim conceals deep inequities in the pandemic's spread, impact, and response. And this, of course, goes back to the very pathogenic nature of the SARS-CoV-2 virus, its incubation time, its capacity for asymptomatic transmission over weeks, its reproduction rate, and its resulting silent spread in communities that cluster in specific patterns. These patterns are anything but random. They disproportionately affect people who perform essential work in crowded spaces, live in dense neighborhoods, multi-generational homes, and congregate settings, and possess pre-existing vulnerabilities such as chronic disease, stress, and food insecurity, all of which intersect with race and immigrant status. And to his credit, President Biden has properly recognized this, creating, for example, a COVID-19 health equity task force chaired by Dr. Marcela Nunez-Smith, and members of that task force bring diverse expertise in children's health, disability rights, prisons, and other neglected issues. But the critical question is, how can this commitment to equity inform American leadership in global health? Well, in the first instance, I think the United States needs to share its vast expertise and ingenuity in promoting health equity with other countries. This should include everything from how to use data to target the most vulnerable and disadvantaged communities with public health interventions, to how to reduce racial disparities in the social determinants of health, such as housing and employment, to how to use indices of disadvantage to optimize vaccine rollout, to how to design and shape an equitable path to recovery. This would be consistent with USAID nominee Samantha Power's articulation of a can-do approach to American foreign policy, in which the sharing of expertise with other nations strikes a contrast to the incompetence and isolationism of the previous administration. In addition to this, a second approach would, of course, be to advance an approach to global equity, in particular by addressing the systemic barriers to equitable vaccine development and manufacture that I mentioned before. But on perhaps the deepest and most transformational level, leading with equity in global health means learning from the ways in which global health and development have themselves deepened inequality and injustice. Long before the breathtaking co-occurrence of a global pandemic with a global uprising against anti-Black racism, a growing number of development experts and practitioners had been calling on the field of global health to rethink a set of assumptions and practices rooted in what some view as its imperial past. These include the pervasiveness of foreign researchers studying health and development in low and middle income countries, the setting of development priorities in remote global capitals, and the substitution of charity and voluntarism for changes to the systems that give rise to this need in the first place. Last month, an editorial in the New York Times exemplified the growing momentum behind these calls to decolonize global health, fueled not only by the Black Lives Matter movement, but also by mounting frustration with the Western-centric assumptions of many aspects of the COVID-19 response. While the demands and recommendations of this movement are complex and draw on decades of development thought and could take up an entire talk of their own, an important and pervasive theme is the need to put more money and power into the hands of communities themselves, rather than viewing these communities as passive beneficiaries of Western largesse. Meeting targets for the proportion of American aid that goes directly to local and national groups would be an immediate leadership step that is consistent with the Biden administration's express commitment to racial equity. This, to me, speaks to a larger leadership imperative that may, in the end, represent our greatest reminder from the past year, and that is the importance of listening. There is, of course, nothing new about the concept of listening in global health and development. It has long been seen as essential to understanding the needs and perspectives of development partners, responding sensitively to local context, and testing and validating our assumptions and implicit biases. What has changed in the past year, however, is the humble recognition that many of us who thought we were listening, in fact, were not. The reasons for this are partly structural. Many of us in global health exist in largely homogenous and elite echo chambers that reinforce our implicit biases, protect us from racial discomfort, and enable self-congratulation. It should come as no surprise that diverse leadership teams are the ones more likely and able to prioritize elevating and empowering community voices. In 2014, the Black American politician Heather McTeer Toney was invited by President Barack Obama to serve as regional administrator for the Environmental Protection Agency's Southeast region. Reflecting on that experience, she offers what I think could be a leadership manifesto for global health in the post-pandemic era. She writes, "Our team was 90% Black women. All too often, I secretly wished for a hidden camera to take a picture of the faces around our conference room table when a guest realized that we were the leadership team. And while our team was not perfect, we agreed that elevating and empowering the voices of the community was our priority. We would create seats at the table, even give up our own if need be. In this view, American leadership in global health is not only about who we invite to the table, but when we know it's our time to leave. In conclusion, I believe it is neither realistic nor desirable to ask or expect the United States to abdicate a strong leadership role in global health. The question is how we lead. I've described 3 dimensions of leadership that each in their own way seek to liberate us from the self-imposed constraints of more traditional leadership styles. These constraints include the myth of scarcity, the lure of false choices, and the perpetuation of exclusion. In their place, I am putting forth a leadership style that emphasizes sharing abundant power, strengthening public safety nets, and diversifying voices in leadership. By design, each of these traditional constraints, scarcity, false choices, and exclusion, serves to maintain the very status quo that impedes progress in global health. Those who are most left behind by health programs know all too well that there is plenty to go around, that there are no false choices to be made if only we create the conditions for human thriving, and that communities know best how to solve their own problems. And yet we all remain trapped in a system that takes these constraints for granted, thus limiting our imagination for change. In that sense, leadership in global health is precisely about the courage to see beyond received wisdom and to tell a new story. Much of what inhibits this kind of global health leadership, in my opinion, is the disciplinary silo of health itself. I think that when we view global health as a primarily medical enterprise, the prevention and treatment of disease, we may be more likely to fall prey to a scarcity mindset, to false choices, and to exclusionary practices. We might concede, for instance, that there are only so many vaccines to go around, that we need to sacrifice our freedom to prevent contagion, that diseases don't discriminate. Each of these concessions represents a failure of imagination, a failure to recognize that human health is about so much more than the presence or absence of disease, but as the World Health Organization says, about the full set of conditions in which all people can have an opportunity to attain complete mental and physical wellness. Achieving this more holistic and human rights-based vision of health thus requires moving beyond self-imposed constraints on our imagination. In the end, this has always been the core insight of the health and human rights field, that the conditions that determine human health lie well beyond what we narrowly and unimaginatively define as the health sector, and that these conditions correspond to a full range of civil, political, economic, social, and cultural rights. This approach requires global health leaders to tackle complex problems that transcend medical disciplines and to acknowledge the complexity of human lives. It requires us to move beyond that command and control style of public health leadership in which health officials simply dictate and enforce healthy behaviors, and towards an approach that provides people with the information, tools, and supports they need to make healthy choices. So in the end, perhaps it is the human rights approach that provides the most fitting touchstone for what American leadership in global health ought to look like today. For it is that approach that dares us to imagine a different world.
Thank you. Thank you. And as I said when you began, you always help us to think about the world a little differently. You talk about the importance of thinking about the US taking on this role. Right. And then you say, I mean, as I wrote down here, that more US leadership is needed, not less. Right. And so my question to you is, do you mean that then for all countries of the world? Or is this something specific to US? How do you think about that?
I think you have laser-like zeroed in on one of the implicit and underdeveloped assumptions of this talk, which is the idea of a superpower, and I guess, in some ways it would be enough to say, I'm talking about the US because that's where we are and we're American and it's timely, and Samantha Power just had her confirmation hearing yesterday and everybody's talking about this, and Peter Beinart's opinion piece, and here's my take. But I don't think that's enough. I think we need to unpack this idea of a global superpower. And I think that the part of the presentation where I talk about the changing geopolitics, right, where, Europe now has as much purchasing power as the US and is responsible for its own security, is what compels a different style of leadership from the historic hegemon. So that's really the assumption that I'm making. But it's interesting because for a while, as I was preparing this, I was thinking, no, the point that I really want to make is that, or the kind of conceit of this talk, I want it to be, of course we need American leadership, but we need leadership from every single country, and it's that, and I'm really interested in that too. And some people refer to that as the coactive leadership model or the collaborative leadership model, where it is the job of everyone to, in a sense, produce and facilitate the leadership of others. So I don't know, why didn't I go in that direction and emphasize more multipolar leadership in global health? It's a good question, but it's not in tension with what I'm saying, certainly. Yeah.
Okay, that's super helpful. That's super helpful.
Yeah.
For all of us to be thinking about this. What's the most effective way to convince people, state representatives, to move beyond scarcity thinking?
I think it's going to take, well, look, first of all, it requires understanding the difference between a scarcity approach and the systemic changes that are needed that underlie an approach that is rooted in abundance and variable sum power. So that's why I give the food example, right? So it first requires being really smart about what those policy changes are that produce abundance, right? So in the case of vaccines, it's being very, very specific that it's about sharing intellectual property, it's about diversifying manufacturing, right? And really having those asks and changing the conversation so that it's about that, and it's about the things that actually get you away from scarcity. And then, of course, as in any policy fight, it's about producing evidence for why those things are effective and get you to where you want to go. But I also think that this is where narrative strategies are so important, because we are, in my opinion, wired to think in terms of scarcity. Of course, there aren't enough vaccines. Everybody knows that. It's like, why? Wait, it's a story, right? That's almost biblical in its convention, And I am super excited, and I didn't get a lot into it, but underlying all of this is my incredible enthusiasm for the exploding field of narrative practice and narrative change, because we have to tell a different story. I mean, the scarcity model, as I alluded to, is so often used against immigrants, right? It's like, oh, if you're getting a job at me, it must mean I'm not getting one. And, even here in California, you have incredible people like at the Annenberg School and the Pop Culture Collaborative who are literally working with cultural institutions, with Hollywood, with TV shows to tell a different story, which is a story of abundance. There's plenty to go around. And so I'm really excited by those narrative strategies as well.
Where should the decision be made on what the style of leadership for global health should be? Is it for the US to decide? Is it for the US government, the US people, other countries? Who decides and in what way and how? Then the second question is about along the lines of the shifting GDP and power relations between the US and the EU. Where do you feel that the US has opportunity to demonstrate the shift in foreign policy, utilizing a transnational lens or some other way? Like, how could the US play with that? And then third question comes from me, I have to admit. Okay, but the third question is about when you ended on the value of human rights and a human rights approach for states and for state action, I wondered if you could elaborate a bit about what that means to you and what that could look like.
I suppose I wouldn't have written this if I didn't think that the decision about which style of leadership should be taken is one that is within the power of individual leaders to make. It's about, yeah, how you show up. And I think implicitly, if I'm honest, like so much of what inspired this topic was that we're in the middle of an appointments process in the US. And it's like every day you read about a new nominee and a new appointment coming out of 2020, where no matter what sector or kind of institution you work in, whether it's arts and culture and the media or philanthropy or education or law or whatever, there has been a profound reflection on leadership, you know, and particularly diversity, equity, and inclusion and inclusive leadership. And that's also true in government agencies. And you'll all have read, or many of you will have seen the stories, you know, because I talked about USAID a couple times about what a difficult year it's been for USAID and how they're just convulsing and making all kinds of demands for transformational leadership around racial equity and so on. So I think it's up to individual leaders. And, you know, whenever a new appointee comes before a Senate committee, I'm sort of sitting there in my little virtual peanut gallery thinking, ask them their leadership philosophy. Yeah, right. So I guess in that sense, it's up to our elected representatives too, the ones who do the oversight of these agencies, to expect a certain kind of leadership as well. And look, if the last 4 years taught us anything, it's that leadership tone gets set at the tippy top, you know, so it's definitely up to the president and what he expects from his appointees. Where does the US have the opportunity to demonstrate a shift in foreign policy that acknowledges changing geopolitical realities? Look, I think in every traditional sector of foreign policy, right? Defense, diplomacy, development, and here we're much more focused on the development sector. I think that the examples, I mean, I suppose the immediate opportunity, you know, we rejoined Paris, we rejoined the WHO. There's a long list of treaties that we have not ratified or absented ourselves from. That would be an immediate opportunity as well. So I guess that's, yeah, how I want to answer that one. And then elaborating on the human rights approach. I mean, you know, we've talked about this before, and I'll put in a little plug for our little webcast, or, you know, little online conversation we had. I mean, I think for one thing, it requires a very, very expansive analysis of the social determinants of health, that extends to all aspects of like economic life and housing and employment, and then working in a multi-sectoral, interdisciplinary way, but in some ways I sort of want to ask you the question, Sophia, because it's like, how is that different from what we've always said? And in some ways, I guess it's not that different. I guess it's just, what I'm saying is that point that we have always made, right, about acting outside the health sector, working in a transdisciplinary way, also corresponds to a philosophy of leadership that feels very current right now.
Are you optimistic? Are you optimistic about where things can go?
This talk about getting older. I would say, the older I get, the less I am optimistic and the more I am hopeful. And I say that because I am a natural optimist, but there's something about optimism for me that has always implied a kind of idealism, and frankly a set of blinders. Healthy, they're great blinders to have, trust me, but they're blinders about what could go wrong, and this is why it's hard to be around pessimists for me, because they're always seeing the booby traps, and here's why this isn't going to work, and here's what's going to go wrong. And it's hard to be optimistic and to maintain idealism after the past year, to be totally honest. But hope is a more sacred thing, and it's radical, and it's a kind of resistance. So I've been thinking a lot about hope.
All right, well, and I feel hopeful listening to you. How's that?
Good.
Let me thank you all actually for the excellent questions and for being with us, but mostly Jonathan, obviously, to you. Your good humor always, your substantive engagement in terms of the responses, the issues you're trying to put out there for us to think about. And I really appreciate you taking the time to put something out that you're trying to work on and that you're trying to work through, and to do that with us in that way. And I hope it was helpful to you as well, as much as it was enjoyable to us. And so thank you so much for this and for coming and joining us.
Thank you. Thank you, Sophia. Thanks, everyone.